All right. Hello, everyone. We'll go ahead and get started here. Thank you so much for participating in the virtual corporate challenge presented by Elevance Health. My name is Patrick Corbett, and I'm happy to welcome you to today's health and wellness webinar presented by Franciscan Health. All right, and now without further ado, it is my pleasure to introduce Dr. Andrew Hills, who will lead today's session. Dr. Hills is a sports medicine specialist with Franciscan Health and specializes in diagnosing and treating several non-surgical musculoskeletal injuries. He also offers neuromusculoskeletal ultrasound, electrodiagnostic testing, fluoroscopic guided procedures, and orthobiologics, such as PRP. He completed his residency in physical medicine and rehabilitation and his fellowship in sports medicine. In addition to seeing patients in the clinic, Dr. Hills is the head team physician at Mooresville High School and assists with coverage for the Indianapolis Indians, Butler University, and Purdue University. Dr. Hills, thank you so much for being here today, and I'll let you take it away.
Perfect. Thank you for having me. Let me make sure I can share this the right way. Perfect. Are you guys able to see that okay?
Everything looks good?
Perfect. Um, so thank you for that introduction there. I do have like a slide about who I am, but I'll kind of briefly, pass that given the great introduction he already gave me. The only thing I would kind of add that, the thing that kind of brought me into the sports world was kind of before all my medical training. I also did some athletic training work kind of before med school at Ohio State. And then was out in Phoenix, Arizona for about 4 years before I decided to come back to the Midwest. And um, I still think I'm pretty, consider myself new to the area as I've really only been practicing in the Indianapolis area since August of 2023 and predominantly practice out of the Franciscan locations in Plainfield and Mooresville. But kind of my kind of quick outline here. Really, there's kind of three big things I kind of want to hit on and kind of addressed. And really, I kind of based this off of just kind of really my most common kind of questions I get every day in the clinic. Um, Starting with some of the concussion management and kind of overviewing some of the current guidelines. They update them every few years, and they were most recently updated in 2022. Kind of the middle of this presentation, kind of want to talk about just usually, more of the most common like MSK questions I get in the office. Just kind of as a little foreshadowing, a lot of it tends to be, you know, kind of addressing kind of, how can we, age kind of successfully to kind of prevent, those degenerative changes and kind of how to kind of keep us active as we kind of go through the years there. And the last thing I kind of want to hit on is just, nowadays a lot of people are talking about like regenerative, medicine, stem cells. So I have a few slides about that towards the end, but hopefully kind of stimulate kind of an open conversation Q&A session at the end is kind of really my main goal here. So first thing I want to kind of hit on is, concussions. I know it's been pretty hot topic, over the last 10 to 20 years and um, pretty, I would say pretty common knowledge nowadays, especially with the, publicity with a lot of the professional athletes. So, starting off with just the definition, if you kind of look at what like the experts say the actual definition is this long, complicated, like lengthy definition. So their definition is a traumatic brain injury that's caused by a direct blow to the head, neck, or body, which results in kind of a force being transmitted to the brain. And basically, that force causes this cascade of chemicals, potentially leading to damage to the nerves, and then, affects, multiple systems that our brain kind of controls. So it's this very, complex kind of pathway or kind of pathology that occurs with these head injuries. But the frustrating thing is there's no like great tool to diagnose this. So that's like on the sideline and dealing with athletes. That's where it can kind of be somewhat complex, just because a lot of the evaluation does have a subjective kind of component to it. People, talk about imaging, for head injuries. And from a purely concussion or mild brain injury standpoint, a CT scan or an MRI is going to be normal. So unless there's any red flags, on physical exam, they're not really too useful from a concussion standpoint. Now we are trying to develop, newer technologies to get more objective data, but unfortunately, there hasn't been a clear, consistent, like kind of guideline on what's potentially helping us versus other things. So we're looking into things like functional, MRIs where, we can see different, kind of patterns on the MRI. But again, you know, it's kind of there's still not a lot of great research. There's also we're trying to develop, like blood tests. Could we potentially, if someone, got into, a car accident or something like that, could we potentially, draw their blood and then there would be a certain marker that would be elevated that would tell us whether or not someone sustained a concussion. Um, and then this bottom left, this kind of mouth guard piece, is kind of, I don't know if she's on the call, but is there's always the new technologies kind of coming out, and the thing that we always got to remember is, a lot of the stuff hasn't been truly, researched in a, clinical setting there. So we just got to be mindful of, even though a product has gone through some kind of laboratory testing, that doesn't necessarily mean it translates to the football field or to the sideline, or the ER there too. And then also we got to, interpret that, what do those testing results actually mean for the patient as well. Now there have been some more recent, I don't want to say like recent, but over the last 10 years or so, we have, changed a little bit of our strategies, for treatment of concussions. So I would say historically, 20, 30 years ago, if, when someone had a bad head injury, concussion, they would tell them to basically sit in a dark room, avoid electronics, basically just kind of isolate themselves almost. And we would call that like cocooning. But more and more, research has come out that shows that isolation can actually potentially, not necessarily delay, recovery, but potentially increase the risk of prolonging someone's concussions symptoms. So for me, I'm a big believer in no longer recommending like strict rest. So a lot of the things I'm telling, patients to do after a head injury in the clinic is to start to try to get, as active as possible, try to do as much of their normal, activities of daily living as they're able to tolerate. And, we actually have some pretty good research articles out there that has looked directly at screen time, whether it be a cell phone, laptop, computer. And, avoiding those technologies, at least for the first 48 hours, can be helpful in regards to symptom management. But outside of those 48 hours, whether or not you're using a laptop or avoiding technology, it really hasn't shown to make a huge difference in regards to, outcomes and recovery. And similar to that, I'm really, encouraging that people can start light physical activity, whether it be, going for a walk outside, doing, I mentioned cycling. You do want to be careful with that in case you have a crash or something like that. So I'm recommending more of a stationary bike, at least at the start. But it's okay to, start doing those activities. And kind of how I kind of educate, patients is to kind of put their, whether it be a headache or dizziness or something like that, give that give that symptom like a number on a scale of 1 to 10 before you start that activity. And basically, if you're watching TV or going for a light walk or a light jog, let's say you give your headache like a 3 out of 10. As long as that headache doesn't creep up by more than 2 points, so it doesn't turn into a 6 or a 7 out of 10, I'm okay with people kind of continuing that activity. Now, the big caveat to all of this is, we still want, people to avoid situations where they're at increased risk for any kind of contact or high risk activities. So that's why, for our football players or athletes, we're still telling them that they can't participate in sports because we don't want them to, be at risk for a second head injury as they're still recovering from the first one. Um, so that's where, we got to be careful in that regard from a sports standpoint. Now, the other big thing I also hit on is sleep. So, especially in America, we're all, busy and bad with sleep to begin with. But there's really good evidence that poor sleep is associated with, longer recovery. Um, so for me, at least in the clinic setting, this is like a big point I hit on, right off the bat. And for most things in medicine, I'm fairly conservative in regards to, I always think less is more. From a concussion standpoint, most people get fine, just with time. But sleep is the one area I'm somewhat aggressive in because, I want to make sure, people after head injuries are getting at least 8 hours of sleep every night. And if they're really struggling, to get those 8 hours or their sleep's interrupted, I'm pretty aggressive in regards to like using things like melatonin or other sleep aids. Just because, again, I think that's an important time when the brain is recovering. Now, this is kind of, I know it's kind of a small font, but these are kind of my more like updated kind of return to sport kind of criteria or progression. We used, at least, a lot of, sports docs, it used to be like a 4 to 5 day kind of return to play protocol that you would begin, once, asymptomatic. Again, because we're trying to nowadays encourage more physical activity earlier in the course of the concussion recovery, um, during at least, especially, high school, college, professional athletes, again, I'm okay with people having some symptoms during the first 3 stages of that return to play progression. So basically, the 5 stages I have is stage one is kind of like light activity. Stage two is a little bit more physical. So instead of maybe doing 30 minutes of aerobic activities, you're going up to like 45 minutes. Stage three is like sports specific exercises, but you're still away from the team environment because you never know when you're going to get hit by a teammate or a ball or something like that. They've and then beyond that, we cannot go past, stage three or day three until we're completely asymptomatic or have no symptoms. And then that's when you do a non-contact practice and then a full practice. And as long as none of your symptoms return during that progression, then you're finally cleared for sport. And the thing to always keep in mind is, school is always more important than sports. So before any of this, really can take place, at least with a student athlete, they need to be back at school without accommodations. And for most people, that's usually always within 10 days for about 93% of all concussions there. Now, but usually by the time they make it to like the sports, med kind of office there, usually they've been having symptoms going on for a few weeks. So that's where, I do think seeing whether it be someone that specializes in concussions or sports medicine, I think this is where we really kind of come into play um, to kind of help manage these symptoms. So basically, any kind of post-concussion, like we're getting away from the word post-concussion syndrome. But anyways, we kind of define it as persistent symptoms after concussions once your symptoms have lasted beyond 4 weeks. Now, this isn't totally like atypical to have symptoms, beyond 4 weeks. About 20% of all concussions or mild brain injuries last longer than a month. But on average, most concussions take about 3 weeks to fully recover from. And what our goals is to try to determine, are those symptoms still related to that concussion, or is it potentially, a pre-existing symptom? So anyone that has a history of, ADHD, learning, impairments, headaches, migraines, even prior to the head injury, not only does a head injury give us new symptoms, but they also make symptoms that we've already had in the past worse. And then the other things we're also looking at is going back to things like sleep. If someone hasn't been sleeping well due to whether it be a headache or other symptoms, that can kind of have like a snowball effect and lead to, again, these persistent symptoms. So then we get into that discussion of, well, is it still because we have a concussion, or is it just because we haven't been able to sleep well over the last 4 weeks? And, I always make the comment that, a lot of the concussion symptoms, line up with people who can't sleep very well. And this is where, in the military, there's always the, lack of sleep is almost like a form of torture sometimes in the military. So that, again, that's how important sleep is. And this is really definitely when you want to see a sports medicine or kind of a concussion specialist, if you haven't seen anyone by this point, because there are other things outside of, using Tylenol, anti-inflammatories for the headache. We do have physical therapists, who specialize in vestibular rehab, which is, the medical term for balance. So that's what I strongly recommend if anyone has any dizziness or neck pain or headaches that last beyond 10 days. Um, a lot of times too with a concussion, people's eyes can almost get off. Like it's not like there's a problem with the eyes. It's just your two cameras aren't working well together. So things can start to, the eyes aren't functioning well, which can lead to some kind of headaches due to just visual strain. Um, and that's where an occupational therapist who has some extra training in vision rehab can be beneficial, as well as potentially seeing an eye doctor that specializes in the brain, which we call a neuro-ophthalmologist. And then the other thing that kind of gets brought up is kind of the stuff that's in kind of the media, and this movie's kind of fairly old now, but again, this is where a lot of people started getting concerned about, the long-term effects, and why a lot of people, they don't want their kids playing football or any major contact sports. There are, some evidence, especially on the professional side of these kind of long-term effects. The problem, though, of what we have is we don't necessarily know if, the brain, abnormalities that they're seeing on those post mortem kind of brain kind of laboratory findings that they kind of made famous in this movie. Um, is due to, multiple concussions, or is it more the repetitive head traumas, even the ones that didn't result in a concussion that kind of led to that? So that's where some of the debate is, especially for, our professional athletes. The good news is from an amateur standpoint, or people who really don't play any contact sports beyond high school, we have yet to see any evidence of this, or at least have any great evidence that shows anything like this. Um, so this is where, some studies, have shown that amateur athletes, again, because of all these this is where, increased risk for like depression and like suicide, again, from these stories of these professional athletes once they've retired. But we don't have any concrete evidence from, a research standpoint that this happens in any, amateur athletes. Um, and then same thing, they've done some research with some former professional football and soccer players. Again, we've come to the conclusion where we don't feel like they're at an increased risk compared to our normal, population at those ages for any death associated with a psychiatric disorder. However, this is where, in boxers, you get the term like punch drunk. There are increased rates of neurological diseases that we do see in professional football and soccer players later in life. Again, do we, this is one of those situations, does causation equal, you know, or is it more just kind of a relationship kind of thing? But again, we do see um, increased rates of neurologic diseases once you kind of get beyond the college and into that professional setting. So again, I think there's a volume component to all of this. And then the big term everyone talks about, with these long-term effects is CTE. Unfortunately, it's not a clinical diagnosis. It's only a diagnosis that can be made once someone passes away and they take a look at their brain. And then when we talk about these kind of long-term, effects, a big thing that always gets brought up is, I've had two concussions, should I retire? Or I've had six concussions, should I retire? And there's really no clear number for that. Kind of the conversation I have with people, it's more of a team decision, getting everyone involved, myself, the player, their family, all the specialists that they've been seeing. And, when the, the benefits of playing or the risk of, playing a contact sport starts to outweigh the benefits, of the sport is when we start to kind of have those conversations, especially when we're starting to have, head injuries from, it's like we get these concussion symptoms from like a not so, you know, violent, injury. It's like you hit your head against the shelf and all of a sudden your concussion symptoms are back, or the symptoms are lasting months and months and months. So that's when those conversations are beginning to have there. Now, is there anything to kind of prevent, the concussions from, happening in the first place? I do want to give a shout out to my partner last week who kind of gave a luncheon. So hopefully I'm not repeating too much of what he said because I know some of his talk was on injury prevention. But just real quickly, this is, a huge topic we're still trying to research. Over the last 10 years, we've tripled the amount of, articles that we're looking at. The biggest things that has reduced concussions is just changing the policies in sports. So in children and adolescents who play ice hockey after they stopped allowing body checking, concussion rates decreased by 58%. Now we also made some changes from a football standpoint in regards to limiting the number of contact practices. That's shown, a 64% reduction in concussion, but the key thing there is that's practice related concussions. It really hasn't changed the rate in regards to, concussions that occur during a game. Now, there's a lot of debate in regards to do mouth guards reduce concussions. Unfortunately, we don't have any evidence from a football standpoint, but there are some articles that show that it does mildly reduce concussions from an ice hockey standpoint. We just haven't been able to reproduce any of those studies from a football standpoint. Now, the big thing over the last 5 to 10 years, especially with the NFL, are these guardian caps. So, in a laboratory setting, these guardian caps have shown um, to reduce impact forces, again, in a lab setting. But the big thing here is a lot of the lab models that they're using, in the NFL, in the college setting, you can't just buy, online at Amazon or through their website. You actually have to go through a specific rep. So the ones that you can buy for like your high school athlete and things like that, it's not the same thickness therefore, it's hard to use the evidence that they're using in the college and the NFL setting and translate it to our lower levels. And that's what this title is on the bottom left side of the screen. It's a research article that just came out from the University of Wisconsin a couple months ago. And their research article basically found there's no evidence to reduce the risk of concussions by using these Guardian caps. But then the question becomes, well, I mean, it's probably not causing any harm. So there's that argument, which is fair. But then you always got to remember that, especially, at the adolescence level, you got to make sure, that cap isn't giving the athlete that false hope. So now they are, trying to tackle with poor mechanics, so they're launching, coming in with more kind of force just because they feel like they have this extra protection. We saw this, 50, 60 years ago when uh, football added the face mask to the helmet. Originally the helmet, didn't have a face mask, so we had a lot less neck and concussions then because people tackled with less force, but you had a lot more, broken noses, facial trauma. And then once they added the face mask, it definitely helped, the facial traumas, but it actually led to an increased risk of head and neck injuries there. So again, that's where you don't want to have that false protection there. Now, kind of moving on to the second, thing I want to talk about. Again, is kind of the most common questions I get from a musculoskeletal standpoint. And again, a lot of it does have to deal with, how can we age successfully and kind of stay active. So just as a background, the average person, between 50 and 80 will lose about a third of their muscle. So in men, it's about 1% per year, and in females, it's a little bit less than 1% per year. And usually the loss that of the muscle fibers that we lose uh, first is more kind of our power or our strength, whereas we tend to kind of maintain our endurance muscle fibers, a little bit longer. And that's what these graphs on the left side are trying to kind of dictate there. So the two ones on the left is kind of comparing a 100-meter, dash to the 10K. And basically, I know it's kind of small, but if you look closely, kind of in that 30 to kind of 55 year old range, that decrease, which or I mean, it's increasing, but that's your time is increasing, so your speed is decreasing. It's a lot flatter compared to our sprints or our shoulder, where you kind of have that gradual, kind of linear kind of line. Whereas, for an endurance standpoint, it's a little bit more flatter, so we're not slowing down as much initially, but then it slowly kind of picks up once we kind of get beyond 60. So before we can kind of reverse that, what are the actual guidelines is kind of what we want to hit on first. So what usually the American Heart, American College of Sports Medicine, and the CDC is currently recommending is that all Americans should have at least 150 minutes of moderate intensity activities a week, or they can do 75 minutes of vigorous activity a week. And the way you kind of differentiate this is kind of this scale on the left. Because if you're just, and a lot of it's also heart rate. So this is where like a lot of the Apple Watches, Fitbits can also be helpful. So anything, on this graph that kind of under 7, so kind of walking, golf, yoga, that is kind of more in that moderate range. Whereas, soccer, basketball, running, that's more of those vigorous, intensity-based activities. So therefore, from a timing standpoint, you technically don't have to work out as much from a time standpoint, if you want to look at it that way. And then the other thing is the big thing here that, I definitely want to always hit on is that we cannot forget about the strengthening days. So that they also recommend at least 2 days of strengthening on top of those aerobic kind of exercises there. Now, again, a lot of us aren't meeting those guidelines. So in the United States, about 8 out of 10 of us do not meet those guidelines. However, about 50% do meet the aerobic exercise guidelines, so that 75 minutes for vigorous activity, 150 minutes for the more moderate. It's the strength component, I think that's, the big one that I mean, obviously only half or many aerobic, but, strength much worse. Only about 20% are hitting those guidelines. That's what's kind of bringing those numbers down. And I think part of it is just an education standpoint from us physicians because I think it's easier from a physician standpoint to kind of talk to people about getting out there and walking and working on aerobic. But from a strength standpoint, from a guideline standpoint, it actually wasn't really added by our major medical associations until 2008. So I still think a lot of that is just kind of still coming to the forefront because things don't really move super fast in the medical system. Um, and the reason why it's not all about cardio is because that strength helps us otherwhere outside of just function and from a strength standpoint. So it helps our bone health. Um, and this is one of those things as we get older, we can only withdraw from our actual bones. When we're younger, teenage years, that's when we're actually depositing kind of calcium into our bones, making them stronger. But then our bone density peaks when we're between 25 and 30. And then as we get older, it slowly declines. So we can't really reverse that. But by, staying active, weight-bearing exercises, adding strength to our regimen, we're able to lessen that decline or decrease the rate of that decline so we don't develop things like osteopenia or osteoporosis. And honestly, even though we're talking about, we want at least 2 days of strength training, um, pretty much any amount of resistance also reduces any kind of by 20% almost any kind of heart mortality. However, if we do combine, especially from a heart standpoint, if we do combine that with those aerobic exercises, you know, it definitely has a better effect when you combine the two there. But again, any amount reduces mortality by 15%. And it seems like the max risk reduction from a strengthening standpoint is about 60 minutes per week. So going for just overall health, uh, doing anything more than 60 minutes per week, you're not necessarily getting those cardiac gains. Obviously, if you have different goals, like building the muscle hypertrophy, you probably do need more than 60 minutes, but just overall health, 30 to 60 minutes is probably per week is probably good enough. And then that brings us to the misconception of, but lifting potentially causes injuries. And honestly, that's not necessarily true. When we look at the rates of injury, only about one injury for every 3,000 hours for guys actually results in an injury. And if you break that down to um, lifting 1 hour a week, that means, a male is only going to have, one injury every 28 years from a lifting standpoint. And then for a female, it's even a lot less. There's one injury per 20,000 hours there. So, that's a big part of it is helping people kind of getting over that fear of that, lifting doesn't directly kind of lead to injury if you do it improperly. And most of the injuries that we see, especially in the emergency department, are for silly reasons like dropping a weight on a body part. And then if you look at other sports, there's actually more risk for injury than these other sports that we think are, a little bit safer. So recreational running, there's about 33 injuries per 1,000 hours, whereas golf, which we think is like kind of our retirement sport, or as we get older, there's only, 3.3 injuries per, 1,000, which is again more than what we're seeing for lifting there. So again, my big thing is just trying to encourage people, it's not all about, range of motion and flexibility. Strength is a large component to a lot of this. And then, the next question is, how about my back? And again, yeah, I mean, I think that's a fair concern because about 60% of injuries from lifting are due to, squats and deadlift. But more than often, those back injuries from lifting are more due to just doing too much. And even though we make harp about posture with lifting, we actually don't have really great research that actually correlates that to injury. So, you know, again, even though we make a somewhat of a deal about it, we don't have great research that it directly links to injury. And then some people complain that, oh, I'm too old to lift. But there's an interesting study that they had over 100 women over 60 years old. They had them do 5 sets of squats and deadlift, and their weight they used was about 85% of their one rep max. And none of the, obviously, they got functional gains from this, study. But the big thing they were looking at was the injury rate. And of those 100 women, only one person, had a bad setback, and that was due to some mild low back pain. So again, I do think adding strength is huge to our cardio kind of regimen, kind of overall there. And then the kind of the last thing, I wanted to hit on from, a strength can't standpoint and kind of exercising is that too much running can cause, arthritis. And the thought process behind that is all that running starts to kind of lead to some wear and tear, on the joints, which then breaks down the cartilage. And we see that in some of our elite athletes, who have been, doing marathons for decades. We do see that increased rate, of arthritis. However, from, our everyday person or recreational athlete, running actually lowers the risk of osteoarthritis. And that's what this kind of graph is kind of showing if you focus kind of on the one column that says odds ratio. So one means that, you're equivalent to someone that doesn't run, and anything less than 15 years for hip, knee, actually reduces that rate. And when you see a number greater than one, that increases your rate of that. So the only time we're actually really kind of seeing that is for the hip arthritis. But again, is that greater than 15 years just due to that person being a competitive runner, or they're kind of like your average Joe recreational runner that's just been doing it? We don't have great data on that. And then the next thing about that, what I get in the office here is supplementation. So the big thing I get, one is glucosamine and chondroitin. The theory behind that is it provides the building blocks to build and maintain cartilage. So, if we provide the body with more of those building blocks, the goal is to hopefully reduce the breakdown. Unfortunately, still don't have a lot of evidence that proves that point. Maybe there's a slight benefit when you compare it to like anti-inflammatories, but again, the evidence is mixed. Um, However, I don't really notice too many like adverse effects. So for me, the biggest risk here is more the financial component of paying for the supplement. And you do have to give it at least 3 months if it's something you're interested in trialing. But I don't discourage it if someone is experiencing benefits. But again, you got to weigh more the cost versus the benefits there. The other one I get sometimes is, especially from males, is testosterone. As we get, this is our menopause. As we get older, our testosterone rates go down. So can we get more, muscle mass if we take more testosterone to kind of counteract that? And the evidence does show it does help, improve muscle strength and fat-free mass. But the problem is, you want to really talk to your primary care doctor about this to make sure you actually truly have low testosterone. Because there are adverse effects, of taking testosterone. It can increase the risk of tendon tears, especially the Achilles tendon. And then it potentially also increases your rate of heart attacks and prostate cancer as well. So it's something you got to be careful, and it's nothing I really recommend unless someone's kind of had a workup through their primary care doctor that has a diagnosis of low testosterone there. Um, and then, yeah, sorry, time-wise, I'll start to speed up here. Last thing is supplement-wise is the creatine. So again, this is something I actually use. I think it's one of the most popular and research supplements out there. I think historically, it got a bad rap because a lot of people said it caused a lot of fluid retention and kidney failure. However, we have no evidence that causes that in the healthy kind of population. Obviously, you do got to be careful with it if you do have a history of any underlying kidney issues. And last thing I want to hit on is just more the regenerative medicine. So basically, the thing here is what we're trying to do is restore, replace, or regenerate basically cells in our body. So the big thing here is from like an arthritis standpoint. Unfortunately, we don't have a reversal agent for the arthritis or the breakdown in cartilage. So this is where people are trying to get into these regenerative fields to see if we could re-stimulate that. There's a lot of different lingo for it, whether it be PRP, stem cells, orthobiologic, or cell therapies. I've gotten careful with them and recommending them just because the FDA has been cracking down on them because I think a lot of people are trying to use the field's hype to kind of push these products, but there's not a lot of great evidence for a lot of these. Um, we do offer PRP at Franciscan. I do these injections here. The theory is we're using a concentrated platelets, and we're basically platelets are responsible for signaling other cells to come to the area there. So we're using that to try to kind of as a natural anti-inflammatory from an arthritis standpoint. And then from a tendon standpoint, we're trying to stimulate those cells to come to the tendon to kind of repair, the tendon there. So it does get a little bit more technical. So, I don't want to get too far in depth unless someone has like a specific, question about it. But I do think, it is the wave of the future potentially. Again, we're just waiting for more evidence on it. I think we're starting to get away from steroid injections, if possible, because steroids do have side effects in regards to breaking down the cartilage, affecting people's hormones, blood sugars if they're diabetic. So I think we're trying to find these other avenues to kind of use something different than just kind of steroid there. But again, I'll take some questions at the end if we have any more questions about that. And the last thing, before I wrap up is, PRP isn't true stem cells. There are other cellular therapies out there. We do not do them at Franciscan just because there's significant FDA regulations limiting the use in the USA. So if someone's, talking about stem cells in the US, really kind of look into it because it's probably not really true stem cells or embryonic stem cells. So make sure you do your evidence because we don't really have any large research evidence that shows that we can restore cartilage in humans. Um, but for me, that's all I kind of had and open to kind of take any questions.
Yeah, thanks, Dr. Hills. We did have a few questions in the Q&A function. So the first one was, does your treatment plans include vestibular therapy?
Correct. Yep. So for me, from a concussion standpoint, I think vestibular therapy is huge for concussion recovery, especially if you're having a lot of, dizziness that's lasting at least 10 days beyond the concussion. A lot of times the body will figure itself out. But if someone's still having a lot of balance troubles or dizziness, 2 weeks after their head injury, I 100% recommend vestibular therapy.
Awesome. And then another question was regarding younger athletes, middle school and below, are there hidden symptoms to look for since the younger athletes might not know how to describe what they are feeling? The example they provided was regarding potential concussions.
Right. And I think that's where this is where from a sideline management where it's really tough. And that's why we're trying to find, is there potentially some lab test that we could do to make things more objective? Because I've run into that situation a lot where sometimes these younger, uh, patients, they do have a hard time explaining their symptoms. So that's where, on the sideline, not only are we asking them like memory questions and if they have any headaches, but we're also having them run through some balance testing and some memory games to see if we can kind of pick up on anything outside of just them asking questions because yeah, it can definitely be tough. And this is one of those situations, especially in the younger, patients, if there's any question or concern that maybe there's something there, I just go ahead and kind of hold them out. We haven't learned how to do brain transplants yet, so we got to protect the one we got. So for me, if that's the case, I usually hold them out, or at least maybe hold them out the first half and then reassess at halftime kind of thing, or hold them out that game and kind of see how they are. Because some people, can take 3, 4, 5, 6 hours for their some concussion symptoms they actually present.
Awesome. And then does insurance cover the PRP therapy?
I'm sorry, I was kind of speeding through that. So that's a good question. So unfortunately, it does not. So that's one of the biggest issues because again, I would love to be able to offer, more PRP injections because I do think, you know, the steroid side effects the risk are starting to outweigh the benefits, especially from a long-term standpoint. But unfortunately, insurance companies, still haven't bought on just because we haven't developed big enough research studies. Now, there are good research studies out there that kind of prove that is helpful. It's just the number of patients in their studies are somewhat small. So we need to do larger studies to kind of prove to the insurance companies. Now, I am starting to have like people who have workers' comp claims. I have been able to get workers' comp to pay for PRP, but outside of that, I haven't really been able to get many other insurances to pay for it.
Awesome. And then another question just came in. So there's a lot of discussion on mini concussions. If this is a real thing, what is the typical long-term impact look like?
Yeah, and that's where that term it's tough with that term. I think for me, I do think there is, a role for these. I call them more like sub-threshold kind of head traumas per se. Basically, I think what they're trying to get at is, um, you know, like it's more like the football practices, the games, playing a contact sport year round. These impacts do add up. We just don't know, what that magic number is. And this is where it gets to the point of, is 3 concussions too many or is 10 concussions too many? And I think it's, more complex than that because I think that's where it's getting at what this person is trying to ask is I do think even the head injuries that don't cause a concussion also plays a role. So this is where I sometimes have kind of like a brain health kind of conversation with the athlete, especially if they're participating in contact sports year round. So similar to my baseball pitchers, I don't want them to be throwing 12 months out of the year. I want them to take at least 9 or 3 months off from throwing. So basically, they can throw 9 months out of the 12 months and then take a 3-month break and do like cross country or track, give their arm a break. Same thing. I had the same conversation from a concussion standpoint. Maybe it's probably not the best idea to go from football to wrestling to lacrosse, maybe kind of incorporate some non-contact sports kind of into your multi-sport career because I do think playing multiple sports is very beneficial.
Awesome. I think that was all the questions that we had. So, Dr. Hills, thank you so much for sharing such great information about today's topic, controversies and misinformation in sports musculoskeletal medicine.